Hello and welcome everyone to episode 2 of the Nursing, Midwifery and Allied Healthcare Professionals Research Council podcast. I'm one of your hosts, Sophie, and I'm an infection control nurse.
And I'm your other host, Claire, and I'm one of the librarians here in the Trust.
And today we are joined by Georgina Lewis. So what do you like to be called?
Hi, I'm Gina.
Lovely. Nice to meet you, Gina. So tell us about who you are, what you're doing in our trust and all these sorts of things.
So I am an ODP, Operating Department Practitioner by background. I actually trained here in the Trust way back in 2002. And back then it was an NVQ was the standard for ODPs. So that's what I did to qualify. And eventually worked out that actually to keep myself in line with the nurses, I was going to need to do a top-up degree, which I went away and did. And at the same time, I was still working in the Trust, been working mostly in scrub, but a bit of anaesthetics as an ODP kind of background, and did my top-up degree at the same time, so did that via Staffordshire University. And then about 10 years ago now, I branched out and did something slightly different, and I started working with the gynecology team as a surgical care practitioner, and I was the first ODP in the Trust to branch out into that kind of advanced role.
So what's the difference? I was just going to say, what's the difference between an ODP and a surgical care practitioner? Because I've not heard of those before.
Also, big shout out to all the ODPs out there, because I feel like the role is really hidden. If you don't work in surgery or theatres, you just don't really know about the role.
It's hugely hidden, and that's one of the reasons I was so keen to come today, because I'm hugely proud of being an ODP by background, and they tend to be undervalued and not necessarily heard about. I jokingly say to the patients sometimes, it's okay if you haven't heard of us, because you're usually unconscious when you meet me. That's my usual
theatre humour.
Exactly. In terms of the different roles, there's lots of different roles within theatre that people don't necessarily have heard of. So ODP is obviously the sort of baseline qualification. They are in line with the nurses, but specific to theatre background. Mm-hmm. My role as a surgical care practitioner is an advanced role, so it is designed to assist for major surgeries. But there's also, confusingly, another role called surgical first assistant, which is how I got into it. So I became a surgical first assistant first of all, and they do exactly what they say on the tin. So they're assisting the surgeon, but they're not doing any of the operation. Surgical care practitioner is the next level up, and that means that we are assisting for the procedures, but we're also doing some minor procedures. So in Gynae, I will do hysteroscopy, putting in coils, etc. There are also vascular and urology SCPs in the Trust, and they will do minor procedures for their relative specialist subjects, and they will also be in clinics. They'll be outside of theatres as well, so that's why it's a more broad role, and one that was slightly more unusual for an ODP to do, because while I was very experienced in the theatre side of things, I had a lot of learning to do when it came to clinics and pre-assessment and actually speaking to conscious patients.
Obviously, is that a side of it that you particularly like then?
It is. Yeah. It's hugely advantageous to be able to see the whole side of surgery. So the one downside to being exclusively in theatres is you don't see the world beyond that. Mm-hmm. So with an SCP, I get to see the patients right from the beginning, potentially all the way through diagnosis in clinic, and then afterwards as well. So we also get the feedback, which is one of the nice things that I get to feedback to staff in theatres as well, because they very often don't get the thank yous and the appreciation. And it's
and you can see the whole patient journey, and
it's much more about
see
the
them
whole
as people.
Human rather than just the operation.
Oh, fantastic!
Brilliant. So, I know that you have written a couple of book chapters in your time. Well, probably more than a couple, actually.
It's
How
now
many of you?
Three. So the first one was Pudner's Nursing the Surgical Patient, which was particularly hilarious given that, as I say, I am not a nurse. So you had a non-nurse writing a nursing textbook, and then it expanded out. And the most recent one that came out in March of this year was for surgical first assisting. So as I mentioned earlier, surgical first assisting is a sort of in-between role. So you are assisting for the operation, but you are not participating, you are not actually doing that operation. And again, it's been an expanding role, particularly since junior doctors' time is so precious and fragile and reduced hours, etc. So they've been around for a good few years now, but although there are training courses out there, of which I do teach on one in Birmingham City University, there weren't really any textbooks specifically for non-doctors assisting in surgery. So there were lots for, obviously, doctors learning how to do operations, and there was some comments within those books about how to assist if you were a junior doctor, but there was nothing for non-doctors to learn how best to assist. So my colleague up in Birmingham, Julie Quick, and one of the lecturers down here now, he's moved down to Gloucestershire Uni, which is Mark Owen, they were the two main editors for the textbook and contacted various members of the team that they'd worked with previously and people that they knew were really passionate about it. And I contributed the chapter towards hemostasis, so how you control blood loss as a surgical assistant and your role within that.
Amazing. And can all these be found in the library, Claire?
They can.
Way.
And some of them are even signed.
Oh, nice. So to be sure to check these out then.
Absolutely. So, so I suppose from a kind of research council perspective, we're particularly interested in, how you end up kind of doing kind of bits of research, writing. What would you recommend? Have you got any tips?
Some of in my cases was not quite an accident, but there's a very famous story among my friends about how I went to an ODP conference symposium a few years ago, and they had a talk about ODPs working in enhanced and extensive roles. And I thought, that looks interesting. I'd really like to go along to that because there's not many of us. So when I applied for my ticket, I put that on the thing that I'm really looking forward to this one, and accidentally ended up presenting on it. So that is a sort of infamous story about how I then made contacts with various other people, ODPs, doing different things. Some were infection control, some were in research. And that was where I made some of my contacts. So my top tip would be say yes to everything, whether you think it's necessarily connected or not, and you never know where it would lead. And also, don't assume that because you're not a nurse or you're not a doctor that means no, because very much there are lots of allied health professions out there. It's not just ODPs that are experts in their area and their field, and that's really needed. So, for example, I am also a peer reviewer for the AFPP journal, and I would recommend definitely any other allied health professions out there, whatever your journal is or whatever your institution or your college is, contact them because they will have projects on the go, and they will, whether that's as a peer reviewer, whether that's actually as research projects, whether that's audit, there's lots of different ways of getting involved, and sometimes one thing can lead to another.
That sounds fantastic.
Brilliant.
And I guess also not only networking within your own organisation, but branching out too.
Definitely.
Going to conferences, talking to people, be nosy.
Oh, definitely. Right? I'm the queen of nosy. I love
Curious
knowing what
nosy.
other people are doing.
Yeah.
And I imagine that the more you do say yes to things, the more you then get asked to do more things. So it's kind of like gets momentum, I suppose.
It does, and it's surprising who you meet through different things. As I say, it was my teaching on the side at Birmingham City that introduced me to Julie Quick. Julie she's just given it up, one of the lead editors for the AFPP journal, hence sort of going into the peer review side of things. And also with the textbook writing, that was something that she and Mark, who's now down in Gloucestershire, had been passionate about, had been wanting to organise for years. But it's a huge project to try and take on by yourself. And I guess that's another top tip. Don't think that you have to do everything by yourself. There are people out there that can aid you, can develop you, can guide you, and you can work together very nicely with.
We talked a bit about that on the last podcast, didn't we? About how, if you do kind of get involved in writing journal articles, you're not on your own. You don't have to write the whole thing. You will get help from the editors and different people along the way.
I mean, absolutely. Being a peer reviewer for a journal, sounds absolutely fantastic. Maybe we need to invite you back for another podcast to kind of talk about that, because there's so much within that, and that's absolutely something I'm really interested in too. So, but having that confidence to be involved with it too, and the confidence to kind of critique people's work and really review it, and have your voice out there and heard, I think is really impressive.
It is, and it's nice. Sometimes you undervalue your contribution and what you actually know, and particularly those professions that are less heard about. You tend to think, well, I'm not a doctor, I don't know what I'm talking about. And sometimes with the articles that I peer review, I do only peer review things that I know what I'm talking about. I don't, for example, I don't tend to review the anaesthetic articles these days because, yes, I was trained as an anaesthetic assistant, but that isn't something that I've done in quite considerable time. So unless it links directly to something that I'm doing routinely, and there are exceptions to that. So, for example, we do robotic surgery now, and the anaesthetic complications and issues with that, yes, that I would be prepared to review, but say anaesthetising a child, no, I don't routinely do that. That's not my area. And most journals and articles will come back to you and say, that's fair enough, we'll send you things that are more within your scope of knowledge.
Fantastic. So it sounds like your plate is very full, but I understand something new has kind of recently started.
It is, which we're hoping to get some new information on soon.
Okay.
We're still awaiting confirmation that we can go ahead with this, so I'm very, very optimistic, and I apologise to the managers that I have been nagging via email this week because I've been desperately trying to get confirmation as to whether this is definitely going ahead before I came to do the podcast. So apologies if any information is incorrect, but I have been given the opportunity to work as a Knowledge Mobilisation Fellow, which is a project of the National Institute for Healthcare Research. And it's not specifically research, but it is to help to bring in something where we already have the evidence that this works. Now, how do you bring it in? So my project hopefully will be HIPEC, which is a type of chemotherapy option used for ovarian cancer patients, which is why I say I'm just being a little bit cautious about how I phrase this, because we're just waiting for this to go through review with the trust that, yes, we can proceed, because obviously financial situations at the moment are a bit of a challenge. But we've been doing lots of work behind the scenes to hopefully bring it in. And my project will be how we support the theatre team particularly, but also the patients. How do we bring this in a safe and productive way when we've got the knowledge and the research that this works?
I love the title of it being knowledge and mobilisation, because often you feel, you know, sometimes when you read research and things like this and you're kind of thinking, how is this relating to real life, real patients and things like this? So this would be really interesting to find out how this project moves. We'll definitely be doing a part 2, absolutely.
Yeah, definitely. And I think there is a gap often between, the evidence and practice, and it is sometimes quite hard to get people to change established practice. Obviously, as a kind of outsider, that's the way it appears to me. Sometimes, clinical staff like to do things the way they like to do them.
I mean, definitely there's so much research coming out about behaviour change, human factors and all these sorts of things.
Yeah.
So it would be awesome to hear how the project progresses.
Yes, and I'm definitely keen on, yes, this is knowledge mobilisation. Yes, the main aim of the project is to support the staff and to bring it in, but there's definitely some opportunities for research in there around all those interesting things as to how we can do it and how we can build that culture that comes with it. I am currently also training to be a professional advocate for the allied health professions, and that is something that's coming in and kind of links into this, that it's about how we support the staff as well as how we develop that research.
Brilliant. Yeah. I mean, from a library perspective, I think that's something we're always interested in. Obviously, a lot of the work we do is around kind of evidence, but we know that the evidence doesn't always kind of turn itself into practice, which is why we're always keen to get teams talking about what's the evidence, is there a way, does it resonate with you, is there a way that you can change your practice? Do you want to change your practice? If you don't want to change your practice, why don't you want to change your practice? All that kind of stuff.
So have you been mapping out like the next steps? Obviously getting the go ahead is a key one.
That's a key one. I mean, that's going through. It always feels like a long time whenever you're applying for funding, and clearly the financial situation at the moment is a bit of a challenge. But there's lots of sort of practical things, like obviously with chemotherapy, there are a certain way that you have to handle the medications, you have to be prepared for spills, the sort of practical elements about that. Some of those in theatre we already have due to other types of treatment options that are available. Some of them is the kit. We've been down to, I've been to Bath and I've been to Norfolk. So Bath started doing this treatment at the beginning of the year. So we went down at the beginning of the year, which was a bit trying for them because they were on episode 2 of ever having attempted this. And then we're in the background going, well, how does this work? What does it do? So we then went to Norfolk, who have been doing it for considerably longer, at least, well, definitely pre-pandemic. And their teams were fabulous for teaching us various different aspects, and not just from the surgical element, but some of the anaesthetists came down with us because there's actually implications for the anaesthetic side as well.
Right.
So there's very much a lot of aspects around getting different teams involved. You need the anaesthetists involved, you need the surgeons, the surgical team, you also need the post-op recovery and ITU. So there's lots of different elements, and that's even before we mention the patient, because obviously it's a huge discussion to have with patients. So there's lots of different aspects that will be coming together.
Wow.
Big project.
This is going to be huge. This is going to be really exciting, yeah.
But I will say the fellowship is actually part of the NHR. I always get my tongue around that one. National Institute for Health and Care Research, NIHCR, and they actually have a number of projects. This isn't a publicity, I promise. But I did recently attend one of their webcasts where they were talking about various different projects for allied health professions that they've got coming up. So I did think it was an excuse to just have a little chat for other people that might like to get more involved as well in the future. So they currently have various teaching programs on the go. The one that I thought was most interesting, and probably most interesting for the allied health professions out there, was a Developing Research Leaders program specifically for the AHP.
Oh, fantastic.
Group. So it is open to everybody or every AHP, so it's not just ODPs. It is for anybody that has an interest in research and wants to develop in a particular area. They're very open, very sort of open to suggestions and developments. They do also have one that is for people that have already done certain aspects of research as well. I don't know quite so much details about that one, but for anybody who is particularly interested, if you're an allied health profession, their email address is ahp@nihr.ac.uk, and I know the closing date is coming up very soon for that one, so I would recommend, if you're listening in, get your emails off now.
Brilliant. What do you think stops people from getting involved in kind of research projects or writing stuff? What barriers do you think people face?
Sometimes I just think it's a bit overwhelming in the intimidation that it's sort of something that professors do that or doctors do that, but everyday people like us don't do that. And, well, how do I go about it? How do I even start with something? And sometimes it's just getting people to realise that really small things are actually contributing towards research or towards evidence. It might be start with an audit, start with something small like the peer reviews. You don't have to know everything. You're not going to know everything. That's kind of the point. So don't let that intimidation put you off. Start with the small things. So for me, one of mine was doing my master's to become a surgical care practitioner. Now, the dissertation for that was actually a service improvement project rather than specifically research. I'd argue that's more important to what I'm doing, because that's actually going to change things for the patient. So mine was a very small project. It was bringing in PICO dressings, which are a negative pressure wound therapy dressing that they were already using in the caesarean sections list at the time, but we brought them in for our larger ladies having big cancer surgery. So it wasn't that big of a project, really. It was something
But
small.
it's making a change.
And a huge change for patients.
Yeah.
And perhaps try not to be too intimidated and think that you've got to do a nationally recognised project and it's going to go into the Harvard Law Review or whatever. No, start small, because those are the things that are actually going to make a difference to patients anyway.
Yeah,
Absolutely.
well said, yeah.
And, there are lots of different types of journals and different places that you can publish as well. It's not, you don't have to, write a really, really academic, scholarly article. Sometimes like a changing, practice article, like a 2-page thing, is just as useful to people and probably a lot more readable.
Yeah,
actually.
absolutely.
Yeah, definitely more practical. And when you think about clearly in theatres is a very good example, but I'm sure there's examples all over the place. You are working with so many different professionals. Yes, you've got surgeons, you've got consultants, you've got right the way down to sort of band 2. You need evidence that appeals and everybody can understand, otherwise nobody's going to follow it. So what's the point in having some highbrow thing that nobody understands when that's not going to make any difference?
Yeah, and nobody wants to read it because it's 50 pages long.
That's true.
So do you think that theatres is a kind of an area where you're kind of people are open to change, or is it?
They're definitely, it is the sort of cliched place where people study. I think that there's the fact that technology is so prevalent in theatres.
Yeah.
So yes, you get changes from that. So certainly in my career, robotics is a huge one that has come in. There's lots of different changes that actually, thinking back over 22 years and thinking we only used to do keyhole surgery for lap and dies, and that was pretty much it. And now you're doing keyhole. We did a keyhole accentuation last month, so totally keyhole, for want of a better term, everythingectomy. So there's huge changes going on, and sometimes you don't realise that until you're 20 years into your career, look back and think, my goodness, we used to just do bog standard things, and there's so much change. And I'm sure that's the same in lots and lots of different areas. If you're talking about, I don't know, the sort of the chemotherapy drugs that we're using now, if you're thinking about mobility aids and prosthetic arms and things that have changed hugely that I'm not even going to pretend I understand.
And that's before you even get into the whole AI thing, which, I'm sure will impact on everybody at some point.
And actually that's another one of the knowledge mobilisation projects that has already started, was looking at AI and the headsets for patients with psychosis, and whether that could have a calming effect. So that's clearly separate to our trust, but it is in our region that is being studied at the moment.
Oh, fantastic. So regarding the knowledge of mobilisation, where will you be, are you feeding back anywhere to the trust and that people can see what's going on? And
yes, definitely. We'll be fed back to the trust. It's also got links to the local universities. There's various sort of outlets and opportunities for feeding that back. Quite whether anything will be published to that, we'll see how we're going. But yes, very much.
We'd expect an article, won't we, Sophie?
Oh, yeah. Definitely.
And also, it's quite nice for me because there will be opportunities beyond just theatre. So, as I said, that is my first love, that's my background. But it's also, how do patients cope with this? How do we get the information out to patients that this is something that we're going to be offering? How do we start that right from the beginning of their journey? So at the moment, we're sort of giving them information about the interval debulking surgery, which is the surgery that we're doing at the moment. The chemotherapy would then be added at the end of that surgery, so it's how you support them through that transition. So the chemotherapy staff will be involved, the pre-op assessment staff will be involved. There's a huge amount of people that will suddenly become involved in that. So although it's sort of how do you put that all into one article, I don't know.
A series, obviously.
Yeah.
Gina, your plate is so full. You're doing so much. It's really incredible. I really look forward to inviting you back to hear all about it.
Yeah, definitely. Yeah. Well, I think you're an inspiration to all ODPs.
Oh, yeah.
All AHPs, it proves that you can and probably should,
Yeah, I definitely.
get involved in
Clearly,
stuff.
I have a bias when it comes to the ODPs, but I am very proud of my ODP background, and I'm very supportive of any ODPs up and coming. So please do come and seek me out if you wish to pick a brain. How useful that brain is, questionable. But yeah, I'm definitely very pro ODP. So and allied health professions, but ODP will always have my heart.
Fantastic.
Fabulous. Thank you so much.
Thank you.
Thank you.